Right. So the next presentation, my lecture, is going to be on facial pain, but I've also included the trigeminal neuralgia condition in this because it seems to fit quite well. And I've also mentioned a few other areas of craniofacial pain separate from headache, because I think that's where it's best located. So in terms of content, we'll talk about trigeminal neuralgia is the most common and frequently talked about cause of facial pain from a neurological point of view, at least. Atypical facial pain, which some people use as a means to talk about any facial pain that isn't trigeminal neuralgia. It's not how we tend to do it in neurology, but I'll talk more about that. Dental pain, which comes to neurology clinics more than you might think, especially in environments where access to dentistry is poor. And Ramsay-Hunt syndrome type 2, which is probably the one that you've heard of. And I'll mention a couple of other rare facial pain conditions which are interesting and you may see rarely. So trigeminal neuralgia, otherwise known as tic douloureux, the French would call that sort of the sudden pain or the miserable pain. It's an horrendous condition to live with. Patients are incredibly distressed. It's a sudden lancinating electric-like pain through the distribution of the trigeminal nerve, usually one division, and it tends to be the maxillary, so the second, or the mandibular, which is the third, but it can be multiple. If it is just through the ophthalmic, particularly bilaterally, that's quite unusual for trigeminal neuralgia, but you can see it in certain secondary causes, such as multiple sclerosis. The majority tend to be idiopathic. Within that, I would say that some neurovascular conflict, so some impingement of the trigeminal root entry zone, so the nerve as it comes out can be sort of tweaked by a blood vessel. I would include that as idiopathic, but it can be secondary. So you can get structural lesions pressing on the nerve, such as tumours. You can get infiltrating infection, inflammation. So that's why it's important to often image, particularly if there's more than pain. So if there's weakness or any other feature, then we should always image. And multiple sclerosis can be a cause of atypical trigeminal neuralgia, maybe the first presenting complaint. People then get a scan and then we see demyelinating lesions. So it can lead to diagnosis of MS. People with MS tend to have bilateral trigeminal neuralgia more frequently, or having ophthalmic distribution trigeminal neuralgia, which is otherwise quite unusual. There are typical precipitants to trigeminal neuralgia, which I would expect to hear from patients. So chewing on that affected side brings up the pain. They'll always do this little movement, even if the pain isn't there, just sort of anticipating it. You cannot touch their face. You will get near them and they'll just flinch and they won't let you touch it. They'll sort of protect their face. They may have a sort of scarf over their face because a breeze or movement of air across the area will exacerbate it. People lose weight. You may find that they've had teeth removed from this side because they've been to the dentist and they think that it's due to toothache or rotten teeth. They won't be able, and it can be a self-fulfilling prophecy because it's too painful to brush the teeth on that side, so that can then lead to dental disease in the affected area. I've seen men with sort of half shaving faces. I've seen women with half the makeup applied. So these are the things that you would expect to see. Someone who's having facial pain right now, who's sort of touching that area, that is not what I'd expect to see in trigeminal neuralgia. Flares with intractable episodic pain. So people can have trigeminal neuralgia, which comes in bouts. So they may be able to wean down their medication, have a few months free from pain, then it will sort of flare up again. They'll have to build up their medication. It may last for a few weeks, and then they're able to reduce down again. Some people have a chronic trigeminal neuralgia where there tends to be always a level of pain and discomfort. I would expect that more if there's a eurovascular complex, so if there's a blood vessel pressing on the nerve. There should not be other features on examination. Trigeminal neuralgia should just give pain. You would expect to hear this sort of history from it. You should not see facial weakness. The patient should not have a numb face. They shouldn't have deafness. They shouldn't have facial droop. If they have other cranial nerve features, if they have other findings on examination that are focal, there is something structural or infiltrative that's creeping through the skull base and is picking off cranial nerves. That's a red flag. So never, never say that someone just has trigeminal neuralgia if they have features other than pain of a typical description. So in terms of tests and management, I always do an MRI scan if I can, if there's no contraindication, for patients that have trigeminal neuralgia. And ostensibly, we do this to see if there is a blood vessel pressing on the trigeminal nerve root entry zone, because that is an avenue of treatment for neurosurgeons if medication isn't helpful. But it also makes sure that there's no other structural lesion or no other problem that's causing it. Obviously, MS I've already mentioned. I've already touched on this. If there are other features, look hard for something else. And in this example, I've got some imagery from Radiopedia, so one of Dr. DiMuzio's patients. And this patient had left, quite typical trigeminal neuralgia, facial pain, but also developed deafness in the left ear. That is not trigeminal neuralgia. And when they performed imaging, they could see that there was a left CPA angle, cerebellopontine angle tumour pressing on the trigeminal nerve, causing both pain because it affected the trigeminal nerve, but it also affected the 8th cranial nerve and caused deafness. So that's why it's always important to do imaging, particularly in those contexts. In terms of treatment, carbamazepine is the gold standard. If somebody had somewhat atypical description of their pain and had no response to carbamazepine, I would often question the diagnosis. Carbamazepine can be really hard to tolerate. People can feel sickly and imbalanced on it. If they respond well but can't tolerate it, that's not really the same thing. But I would expect people to get good response of pain from it. Other options, gabapentin, baclofen, lamotrigine, they all have evidence as a preventative. And for acute worsenings of pain, you can use phenytoin infusions with cardiac monitoring and lignocaine patches. If you are really struggling to manage pain, or people are very toxic and they do have impingement, then consider referral to neurosurgery. So atypical facial pain. So as I've described, the typical trigeminal neuralgia features. If somebody has sort of a chronic pain in the face, doesn't respond to carbamazepine, doesn't have the same sort of obvious precipitating factors, then atypical facial pain may be the diagnosis. Obviously look for any other lesions or infiltration, especially if there are red flags like deafness, facial droop, weakness, that sort of thing. Imaging of the facial bones and the skull base are important if we are thinking about cranial nerves being affected by structural lesions. If all of that is normal and there isn't any other features but just chronic pain that isn't really like trigeminal neuralgia, we would put this into sort of one of the chronic pain syndromes, and it can respond to pain team input. So dental pain. Neurologists get referred more and more dental pain, and I'm lecturing in 2025 in the UK. Access to dentistry is difficult. A lot of people can't afford private dentistry, which may be the only option which is available in their local area. So people who have poor dentition, they have dental caries, they can get abscesses, they have referred facial pain. And people will come into A&E, facial pain. Oh, it's trigeminal neuralgia, refer to neurologist. I'll go down there and I will see somebody with badly decayed teeth, a swollen red face, and florid infection markers because they have a dental abscess. I mean, there's sort of a fluctuant swollen mass in the face. Dental infection isn't without significant risks. If people have chronic infection of dental areas or of the sinuses, that can track to the venous sinuses and cause venous sinus thrombosis or cavernous sinus thrombosis, so clots in this venous system in the brain, and that can be fatal. So we need to remember that if somebody has chronic dental infection, chronic sinus infection, they come in unwell, drowsy, seizures, get some imaging of the brain with some imaging of the venous sinuses because there are risks there. People can get neuropathic pain or nerve damage after dental injections from the dentist or a root canal. One of the nerves that's more commonly affected is the inferior alveolar nerve, and that gives you feeling in the lower lip, to some degree the tongue. And if you have chronic damage to that nerve or to the sensory nerve, people can end up chronically biting their lower lip because they're not really sure where it is. So Rumsey-Hunt syndrome type 2. So Rumsey-Hunt, he was a bit of a legend, and he described a lot of things. Type 1 was a cerebellar issue, so that's not the one that we're talking about. Type 3 was a form of carotid dissection, but he's famous for essentially manifestations of shingles causing a facial nerve palsy. So varicella zoster is reactivated in the geniculate ganglion of the facial nerve. and that will cause significant deep pain. So like any sort of shingles, there is activation of VZV. People get deep pain in a dermatome. It's the same in the face. It's often deep in the ear, or it can be in the throat or the back of the tongue. It's really important if somebody comes in with this sort of pain or facial weakness, look in the ear, look behind the pinna, behind the ear, look in the mouth, under the tongue, have a really good examination of the oropharynx and the soft palate, because you can see the vesicles of shingles in there. And if that's the case, we would expect, if it hasn't already happened, for people to then develop weakness at the face, like a Bell's palsy, but we wouldn't call it that in Ramsay Hunt. And it's important then to give prompt acyclovir, ideally within 72 hours for the best response, alongside steroids. So it's important not just to give steroids for Bell's palsy without making sure they don't have Ramsay Hunt. And I would particularly suspect Ramsay Hunt that they have deep pain in the ear or in the back of the throat. If people are complaining of deafness with ear pain and facial weakness, I would treat them for Ramsay Hunt. I would have a very low threshold for that. And people, 3/4 of people, if they're treated promptly, tend to have a good recovery with Ramsay Hunt. And a nice picture here from a paper. You can see that this lady has facial weakness on the left. So she's got her eye taped to make sure that she doesn't get any scarring of the cornea. And you look in her ear where she's got some nice piercings, that she's got some healing vesicles within the ear. And they're quite superficial and obvious, but remember that it can be deeper within the ear canal, so you need to look for it. So other facial pains that are a bit interesting. So glossopharyngeal neuralgia, think of this as the tongue version of trigeminal neuralgia. A lot of commonalities to it. So drinking cold things can trigger it off. The tongue touching anything can trigger it off. Treatment is similar, so it can respond nicely to carbamazepine. It's more likely to be bilateral, so it's at both sides of the tongue. More likely to just happen once and never happen again, compared to trigeminal neuralgia. We call that monophasic, but it can recur like trigeminal neuralgia. More common in men, tends to be a bit younger, so sort of 40s, 50s, whereas trigeminal neuralgia tends to be sort of older and less sort of specifically men. Imaging is important though. Anyone that has any tongue weakness, tongue wasting, tongue pain, I have quite a low threshold for imaging because this can be a structural lesion or head and neck tumour. Burning mouth syndrome, quite common. So people describe a sort of feeling of burning or acid in the back of the throat or the mouth. It's quite painful, can feel hot or burning cold, they might say. They might get a horrible taste, which is often metallic or acidic. And in the majority of cases, it's idiopathic. It just is something that happens. It can be due to a chronic dry mouth, a xerostomia, which can be due to a condition like Sjogren's syndrome or due to dryness of the mouth from medications like amitriptyline, for example. You can see it in bad reflux disease where acid is coming up and causing it. Endocrine disorders, thyroid stuff can cause burning mouth syndrome. B12 deficiency, it's been described. Medications can cause this. ACE inhibitors tend to be the typical ones. But there have been reports it can happen in certain hematological malignancies like multiple myeloma. So worth thinking about asking some questions. There's not a lot of evidence about treatment. People have tried neuropathic painkillers like pregabalin, things like that. But antidepressants and alpha-lipoic acid supplements from health food shops have a little bit of evidence. But it's an interesting thing to know about and important to mention. Examine the mouth. If somebody has symptoms in the mouth, in the tongue, it sounds basic. Examine the mouth, make sure there's nothing in there that is abnormal. So, summary. It's really important when people have craniofacial pain to have some knowledge of the things that can happen and some knowledge of the anatomy. If there are other features beyond pain, weakness, numbness, deafness, visual loss, things like that, this is not a trigeminal neuralgia or a simple atypical facial pain. This person needs imaging. I suspect that they have an infiltrative process going on, be it tumour, infection or inflammation. It's important to know what imaging to get, what to ask for and what to think about. So things like think about doing also the facial bones and the skull base and give your radiologist a nice description of what's going on so they can focus on the appropriate area. And primary facial pain can respond well to neuropathic agents. Trigeminal neuralgia, particularly carbamazepine, unusual for it not to respond. Thank you.